My name is Dr. McKenna Mbogori, and this is a technique video on arthroscopic anatomic glenoid reconstruction using distal tibia allograft with Bankart repair and Remplissage. CT scan imaging is used to develop precise patient-specific 3D models and hologram images for visual illustration of the bone defect. The patient is positioned in a 30-degree semilateral position. The 3 standard Bankart repair portals are used with the addition of a posterior inferior portal for Remplissage and the far medial Halifax portal for graft insertion. A standard diagnostic examination of the shoulder joint is done identifying the soft tissue, glenoid, and humeral head bone defects. The anterior-inferior portal is used for debridement of the rotator interval. The goal here is to visualize the conjoint tendon, coracocomial ligament, and the tip of the coracoid process clearly. We then establish the anterior superior portal and switch the camera here, giving us a direct straight shot view of the glenoid. A suture is passed through the anterior labrum, capsule, and periosteum at the 3 o'clock position. This racking stitch facilitates tensioning and eventual later reattachment of the tissues to the 12 o'clock position, facilitating an inferior to superior capsular shift. In revision cases like this one, we encounter previously placed suture anchors that may require to be removed during this release. A liberator knife is used to clear and section the labrum all the way past the 6 o'clock position. The glenoid defect here measured 20 millimeters, and the goal would be to increase this to at least 30 millimeters with the bone graft. We then use an oscillating burr to decorticate the anterior edge of the glenoid, getting it perfectly flat and to a 90-degree angle in relation to the articular surface. We then turn our attention to the Hill-Sachs lesion and using a curette and shaver prepare the bony bed for the Remplissage. A posterior inferior portal is established via an outside-in technique under direct visualization. 2 all suture anchors are inserted through the deltoid and posterior capsule, superior and inferior to the defect, and will be tightened at the end of the procedure. A trapezoid-shaped bone block measuring 1 by 2 by 1.5 centimeters is marked from the posterolateral corner of a distal tibia allograft of the contralateral limb. We then insert 2 wires in the center of the graft parallel to the articular surface. We overdrill these wires, tap the holes, and insert screw caps. The construct is then attached to the double barrel cannula, which facilitates graft handling and insertion. In order to facilitate easy graft insertion, we release some of the anterior soft tissue structures such as the coracohumeral ligaments and adhesions between the subscapularis and conjoint tendon. We want to ensure that the subscapularis muscle can be depressed all the way down to the 6 o'clock position as shown here. The Halifax portal is made using an inside-out technique with the arm adducted to release tension of the conjoint tendon. A switching stick from the posterior portal is inserted superior to the subscapularis and lateral to the conjoint tendon and pushed forward to just under the skin. 2 half pipes are inserted through the skin incision, followed by a channel dilator and finger dissection to further open up the portal. The graft is inserted via the Halifax portal with the help of the 2 half pipes that keep the channel open. Once the graft is inserted and positioned on the anterior glenoid rim, we first aim to get the appropriate position in the superior-inferior plane and secure it in place with 1 wire. We then align the mediolateral and rotational angulation prior to inserting the 2nd wire once satisfied with the position. We then drill over the K-wires bicortically, measure the screw length, and insert cannulated screws of appropriate length to hold the graft securely in place. The anterior labrum is repaired over the graft onto the native glenoid using the standard technique. 3 anchors are used, 1 aimed below the inferior screw, 1 in between the 2 screws, and 1 knotless anchor above the superior screw, through which the racking stitch is passed through, thus facilitating the inferior to superior capsular shift. The final step is the Remplissage, whereby we tighten and tie the sutures of the previously placed anchors above and below the Hill-Sachs lesion, thus bringing in the posterior capsule over the humeral head defect. This is the final view showing the Remplissage posteriorly and the distal tibia allograft on the anterior glenoid with the labrum repaired over it.